Hello, everyone. I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University, and with a joint appointment with Ross University School of Medicine. And it is with great honor that I am presenting this topic in front of the World Psychiatric Association. Actually, this is the 22nd International Congress on the World Psychiatric Association. And I'm presenting this with my good friend and colleague, Dr. Michael Zeroni, from the School of Counseling at Walden University for years. And so we have been discussing this for many years now about looking for linkages, and we have had lengthy discussions about linkages between physical health and mental health. So my perspective and background, of course, was medicine. I was trained as a physician. I've seen patients. I've actually studied public health, and his perspective was more in the area of psychology and counseling and mental health. And so both of us having both conducted research and seen patients in the past, we're able to put our brains together to try to see this connection. And truly, when I say complex in the title, when we said that, we mean it. And we're going to try to simplify things as much as possible in this presentation. But let's go through some of this logic a little bit. So everybody knows hypertension is rates, of course, are high, and it varies by race and gender. It's not um, no one has myths that hypertension is the same across the board, right? The greater percentage is among men than women. There's actually a 6% difference. 50% among men, 44% among women. And also, non-Hispanic Black adults are 56%. Have of them have high blood pressure, whereas among non-Hispanic white population, 48%. Among Asian population is actually lower, and then Hispanic adults, 39%. However, as a caveat, I will mention this that in South Asian population, actually, there's a higher preponderance of not only hypertension but also cardiovascular disease. And if you look it up in the literature separately, if you're interested in this, you can look it up and study this separately. Several of my students have done that before. So in this study, though, that wasn't our focus. The main focus was, of course, understanding the relationship between hypertension and depression and trying to find a common denominator between these two macro concepts. But before we can go set on this on this quest, we needed to make sure to understand what the treatment action is in terms of understanding how to follow up with depression. So initially we mapped out and looked at what areas hypertension was problematic. And as you can see, many of the southern states traditionally even, when I looked at this map about 15, 20 years ago, looked the same. The southern belt has a higher preponderance of hypertension. The worst places being Alabama, South Carolina, Louisiana, Arkansas, and Oklahoma. Um, but going into, of course, the different levels of depression as well is extremely important. And I'm just going to quickly zoom in here and take a look at this table. But just looking at some of these tables, how to treat different levels is important. And those of you that are conducting research, it's important to note that there are different levels, that depression doesn't all behave the same. for lack of a better term. So, what did we do in this specific study? Well, specifically in this study, we looked into 2005 to 2010 National Health and Nutrition Examination Survey. So that was about 3 or 4 cycles of data. Um, Three actually, 3 cycles of data. And then what we looked at was assessing for depression. So if an individual in the PHQ-9 scale, the Patient Health Questionnaire 9 scale, got greater than or equal to 10, then this was considered clinically relevant depression. And then, of course, understanding hypertension. This was from self-reported data and some measurements. And then what we were looking for really is to look for common denominator. And one that I had done extensive work on, and you'll probably see a lot of writings and a lot of literature on this, is C-reactive protein. And some of you who are familiar with this work, with my work, will know that this is something that I look at often. And so anybody who had greater than 1 milligrams per deciliter of C-reactive protein was considered elevated. And so just looking at if the effect of different levels of C-reactive protein impacted how hypertension affected depression, this was what we were after. And I'll explain that to you a little bit better momentarily. But before that, let's look at the distribution of poor mental health. Very alarming, and I almost see if you look closely at the blue map on the right and the red map, or the orange map that I first showed you, you'll see that actually there's patterns that overlap. And so we can already predict that there's going to be overlapping patterns between hypertension and depression. And when we did the numbers, when we crunched the numbers, guess what? We found a significant association between hypertension and the development of depression. 38 times, or excuse me, yeah, 38 percent more likely, 38%, not times, 38% more likely to develop depression in individuals that have hypertension than those without. But what was more interesting, this was the most interesting finding, when you actually had people have both hypertension and be positive for C-reactive protein, the elevated level greater than 1 milligram per deciliter. Then you saw 4 times as likely to develop depression than individuals that had that were positive for hypertension, but that did not have elevated C-reactive protein. So having elevated C-reactive protein actually made outcomes much worse in terms of depression. So something about the inflammatory mechanisms of hypertension, when it's compounded on the pathophysiology of hypertension, leads to the development of mental illness, namely depression. So, in conclusion, there has to be more screening for depression, especially in individuals that have hypertension. But more importantly, we can actually trace biomarkers and track biomarkers and call for surveillance, regular surveillance of these within the general population, especially in the individuals with chronic diseases like depression and hypertension, so that they do not go on to develop mental illnesses, which would then further exacerbate the chronic diseases that they may have. If you look at this diagram, if you look at this figure, depression, anger, hostility, these things, of course, I mean, these are things that lead to kind of non-adherence, and kind of an overactivation of the autonomic nervous system, which leads to all sorts of mechanisms, even neuroinflammatory modulators, which leads to that poor glycemic control, all of these variability of heart rate, platelet aggregation, is activated. All of these things, even homocysteine, all of these things are contributing to increased cardiovascular disease um, when you have depression, anxiety, etc. But also, these arrows, I would argue, go both ways. So, cardiovascular disease is, on the other hand, activating, for instance, ANS, autonomic nervous system, platelet aggregation, homocysteine. Homocysteine. All these are the cardiovascular disease actually contributing these to these two. So I would actually read this figure from the bottom up, if I were to kind of look at this. But again, the approach always is to go towards more personalized medicine and more targeted therapy. I would like to thank the organizers of the World Psychiatric Association for putting this together and putting this entire conference together and having such a wide variety of speakers. Thank you for listening.